So I have to introduce Kaven Baessler. Kaven came to me more than 5 years ago. And she asked me whether we could do some research together on the pelvic floor, mainly to develop special pessaries for pregnant women. Well, we have done so, and we even got some support for industry, but it's not yet certified and it's not yet audited, so we don't sell them yet, but we did a lot of experiments, let's say, in this time. And I think also it will be the future, but it needs more time and more clinical evaluation to be precise. Anyhow, what Kaven was telling me and teaching me is that much more women than I thought have pelvic floor complaints during pregnancy, and this is ignored by their obstetricians. And we just had 2 weeks ago with Holger a workshop in Hamburg, and I had the task to talk about simple things like episiotomy and Baessler maneuver and forceps, and it is really like that. I also made a course in summer to get to know more that a lot of obstetricians really don't care what happens with the pelvic floor. And I feel this is an enormous gap. And even at the World Congress of Ultrasound, which was here with 3,000 or 5,000 people in Berlin in October, there was one lecture on the scanning the pelvic floor. And scanning is really the tool where you now can see that you don't have only anal sphincter lesions. You have much more lesions of the connective tissue which you could discover and treat. And so, Kaven, I leave you the field because she's urogynecologist here in Berlin, and we also have Ladislav Krofta from Czechoslovakia, who is one of the very few who combines obstetrics and this knowledge, so please.
Okay, thank you very much for the introduction. Now I would like you to pity me a bit, feel sorry for me that I'm a urogynecologist, I'm a late obstetrician, so I feel sorry for me doing all this hard work counseling the women who had a traumatic pregnancy and childbirth. So I'm not doing night shifts delivering babies, but I do the hard work later on, which most of the obstetricians don't know anything about it. You see those women back for their next delivery. You don't see them back for all their complaints regarding the pelvic floor. And so my task today was to close the gap a little, to let you know a bit more about incontinence and prolapse. One of the earliest studies, a big data study, actually we didn't call it then big data, the IPIC-CONCH study, Scandinavia has a lot of databases, and they looked at women who delivered only by cesarean section and only by vaginal delivery and compared them. So there was a risk of incontinence which was increased already during pregnancy because cesarean section increased the risk for incontinence by 1.5, the spontaneous vaginal delivery by 2.3. So it was much higher, but still delivery itself is not only a risk factor, it's pregnancy already. And well, the biggest problem really is being a woman. So the most primary prevention of all would be to have a Y chromosome when you are born. So that's compared to nulliparous, and as I said, many nullips have incontinence as well. So we looked at data in Berlin, and this was a doctoral thesis of Melanie Metz. We have a pelvic floor questionnaire which was validated during the study for women in pregnancy and postpartum. And you know, in the third trimester, nearly 50% had incontinence. It decreased 6 weeks after birth and increased again after 1 year back to 50%. And pelvic floor symptoms, a quarter of women in pregnancy had pelvic floor prolapse symptoms, and it did not decrease after delivery and stayed the same 1 year postpartum. So feeling a prolapse, something coming down in your vagina, was a very common symptom in these women. We didn't examine them, we only asked for those symptoms. So these data have been shown all over the world. It's not only in Berlin, but also in Berlin. This study looked at prolapse. Second stage of prolapse would be like here, the anterior vaginal wall being at the hymen, plus minus 1 centimeter, second stage. And they looked prospectively in women in the second trimester, and the third trimester, and postpartum. And in the third trimester, 39% of women had a second stage prolapse. After delivery, still 35%. Cesarean section only had 8%. So clearly there is a risk of having prolapse, and most women having a second stage of prolapse would feel it. It's a hymen, plus minus the hymen when women start to feel the prolapse. If it is higher, they will not necessarily feel it. So we know during pregnancy we have all these hormonal changes. Really, the body is prepared for giving birth, and the baby has to go through the pelvis. So there are a lot of changes. We all know the striae and the varicose veins and so on. So clearly there is a change, and that's why a lot of incontinence actually happens. One study said 80% of women are incontinent during pregnancy. So we didn't see such a high number, but still, it's probably a question also how you ask that. So vaginal birth, and I don't say much more, because this is one of the first computer models that were prepared in the Lenses unit in Ann Arbor. And they took an MRI model of a normal woman, putting in all these muscles, and then on the computer they put this 10 centimeter ball through the pelvis and measured how much this muscle has to stretch really to deliver that 10 centimeter head. And so if you see that, you really can imagine it's not just the muscle damage, it's neuromuscular damage that you have, and this has all been shown in numerous studies, that after delivery you have damage to the nerves, the response of the nerve is different, and the action potentials are different. Has all been shown. The connective tissue is different, can be measured on ultrasound, and we have direct muscle damage with levator avulsions, that's what it is called these days, when the muscle tears off the pubic bone. So they really measured that the pubococcygeus muscle has to stretch 3.3 times in order to let the baby through. No muscle in our body will be able to do so. If you have the biceps 3.3, it cannot stretch that much. The pelvic floor has to. And that it doesn't recover as easily, we can imagine, and probably not in every woman, and that's something we don't communicate. We don't tell women, you will never look the same again down below. You don't tell them that. And, well, they don't know from the internet as well. I see so many women who say, no one told me that. Not my mother, not my sister. Now, a lot of damages, this is from Hans-Peter Dietz in Australia, who was one of the first looking at ultrasound on the pelvic floor muscle itself and how it tears. And this is straight after birth, and he was called into labor ward, and someone said, look, I think I see live what you see on ultrasound all the time. And she had a vaginal tear, and this is a pubic bone, the inferior ramus, and there's no muscle left on that side. So it has torn. And they tried to reattach that muscle. But how do you attach a muscle to a bone? There's no tendon, no nothing, you can suture it. So it wasn't possible. So later on they tried to do it on using mesh, but it's not a good result. It doesn't work as a muscle, so it's impossible. In the middle you see the MRI model, seeing that the pelvic floor, which should be like this, is torn on that right side here, and this is the ultrasound showing the same thing. So later on we see the muscle avulsions on ultrasound. This was one of the rare cases where you have a vaginal tear over that muscle tear. But unfortunately it's not possible really to suture it back. So we have to prevent that damage. That's another 3D image which showing the normal muscle, normal configuration of the vagina. This is after birth, and you see on the left side the V or U shape is missing. So there is a change in the muscle. And we know from different studies all over the world, 20% of women have a beta avulsion during delivery. So that's something we can see on ultrasound. We can use our fingers, and most gynecologists that I have met, they don't examine the pelvic floor. Even after delivery, my gynecologist after delivery, she asked me to do a pelvic floor contraction because she knew how I am. She didn't ask my sister anymore. So they don't examine the pelvic floor. And it's just, you can use your finger, you don't need a 3D ultrasound to do so. You can examine it. And I think this is one of the most important things. We talked about it already regarding being overweight, but we have to tell women more about their pelvic floor. This was Dr. Salton's study on endoanal ultrasound before and after delivery, and he saw a lot of defects of the anal sphincter which were not discovered after delivery. He said, and he published in the New England Journal 93 it was, 93 New England Journal, 33% of sphincter damage not seen or discovered after birth. And later on he said, oh, that's not true, because we did not examine women correctly. It's not just an occult damage, it is that we did not examine them in the right way, and he decreased actually his occult sphincter damage by increasing the real third and fourth degree tears, just because he examined women afterwards. And now they have a very precise setting what you have to do after vaginal delivery, because what is clear is you have to suture it in the right way in order to have less symptoms afterwards. If not sutured correctly, 50% of women who have got these tears will have anal incontinence. That's a very high number, which you can reduce to maybe 5% if you suture it in a correct way. And I would say in Berlin, most hospitals do that. I'm not sure about Brandenburg or somewhere in the periphery, whether they really have attended all the courses and do a proper repair of the anal sphincter and examine women. And you can also use a normal vaginal probe. You don't have to have an anal ultrasound in order to see these sphincter damages, which you can see on the right side. And actually, this would be a very common defect because the episiotomy was far too close to the anal sphincter. You have to have a 60-degree angle of episiotomy in order to avoid cutting into the anal sphincter. All published. We had a nice meeting 2 weeks ago in Leipzig, a workshop with midwives and physios and some obstetricians, but not a lot. And they didn't know. They saw the medial lateral episiotomy somehow to the side, but how many degrees they didn't know. And it's all published, and I think we have to teach more and get people interested in all the defects a normal delivery can cause. So those are a few pictures. As I said, no one tells women what they might look afterwards. And I'm not saying that everybody should have a cesarean section, but informing women what's going to happen is very important. Well, that she's a bit older, she's not right after delivery, but you see a second-degree prolapse, and an open introitus. This woman is about 3 months after delivery. You see the perineum is damaged and the posterior vaginal wall is coming into the introitus. The most common symptom these women have is not, they might not even feel really a prolapse, but what they say is, my vagina is far too slack during intercourse. That's what the first urogynecologist I worked with in London, he said slackness at intercourse, which I think it's a really funny term. But that's what it was called. But that's what they say. Having a rectus seal and a too wide vagina during intercourse. And in all those sexual dysfunction questionnaires, this question is not asked. They ask about libido and how your relationship is, but they don't ask these questions, wide vagina. And women complain of these days. And if they have a man with a small penis, it might not work out very nicely afterwards. And it's not just the vaginal birth, it's probably the connection and relationship. So this is what a normal perineum should look like, the perineal membrane. That's again studies from Jean de Lencin and Abe. And during delivery, the perineum ruptures, or may rupture, let's put it this way. So when she develops this rectus seal, that's the same woman where I put a finger inside, you can still see the scar of the vaginal tear that was sutured. But most obstetricians cannot improve their suturing techniques because they never see the woman back. In Germany, that's the main problem. Most of the surgeons do not see their patients back. That's why we have a lot of unnecessary knee operations and so on, because that's not what a normal hospital is not allowed to do, outpatient clinics. So, but obstetricians, that's really a problem. They don't see them back just for the next delivery. And like this, far too high perineum, she had a lot of pain during intercourse because of this high suture, and no one really examined her properly, or I don't know, she was sent to a psychiatrist. So he took a knife then, and this was one of the things where we could easily help. In our study in Berlin, we had a number of risk factors. So as soon as your mother or aunt has prolapse or incontinence, you have a far more higher risk. Maternal age, more than 35, has been shown in a number of studies. Smoking is good for nothing, being obese is good for nothing. So those are the common risk factors. One thing we asked women was, do you think you can contract the pelvic floor muscles? Yes, no, maybe. As soon as they ticked yes, they had a less risk to have incontinence. So as soon as they really knew what to do, we didn't check whether they really knew, but the feeling was important already. And of course, some of these risk factors are modifiable. One thing, the Your Choice risk calculator, is everybody familiar with that one? Yeah. Based on 2 long-term studies with more than 10,000 women, a group in the States developed this risk calculator. It's Your Choice. Everybody can fill it in online. And it just displays the risk you have with a vaginal delivery, with a cesarean section, depending on how old you are, how much you weigh, how much the estimated birth weight will be, and whether you've had already a delivery. And then it just says the numbers. How many women would have incontinence, prolapse, and an operation for it. And it's a very powerful tool. You just take the woman through it or ask her to do it herself. And the numbers usually are not just if you have a vaginal delivery, it's 100% prolapse, and if you have a cesarean, it's 0. It's usually not that much. And it hardly ever gives advice or says you should have a cesarean section. But it informs women. And I think that's the most important thing. She needs to know. And most women don't want a cesarean. They want a normal, nice, beautiful delivery. They don't want a cesarean section. But to give her some say and to give her the information, I think this is important. I think this is something every woman should be doing, going through this risk calculator. And certainly if you are under the age of 35, your risk is much lower. So, apart from losing weight and not smoking, should we all have cesarean sections or deliver vaginally? I think that's really not the question for me. It's counseling, telling women. And if you tell women, you have to tell them about shoulder dystocia when the baby is more than 4,000 grams. I think that at least that's what's in Germany. So if you do this counseling, you should tell them about pelvic floor disorders as well. There are a number of things that have been shown to reduce the risk, like normal weight, don't smoke, exercise regularly, and that's low impact sports, get to know your pelvic floor muscle. A lot of studies having shown that you reduce the incontinence rates when you do pelvic floor muscle training before delivery. Caffeine, tea, and so on, constipation. As soon as I left London, constipation was not a high risk factor anymore. So a few things that you cannot change. That's the pelvis. I'm not sure about birth weight and circumference. That's why I asked, losing weight, does it transfer into the birth weight? Because the weight has increased over the years. When I was doing my thesis 30 years ago, I think the risk factor was 3,500 grams already. Now it's 4,000. So it has changed. So I think giving birth to a lower, not too low of course, but 3,000 would be really much better for the pelvic floor. Some things we can change: episiotomy, no forceps, rather vacuum if you have to. So any forceps delivery for me, it's a failed indication for cesarean. It's position. Well, hardly any woman would be lying down. Supine deliveries, I think, are not that common anymore. You should do something again for the pain, and a lot of PAs are given these days, and you can manage the second stage of labor. This was just a paper presented at the ICS Society this year, and 12 years after the first delivery, the risk factor for being incontinent and having pelvic floor problems, the only thing that really stood out was the active second stage of labor, more than 1 hour. Active second stage of labor, which is more than 1 hour, is too long. So what can we do if we have prolapse? A number of studies have shown as soon as you are able to contract the pelvic floor, you reduce the hiatus and you can reduce prolapse symptoms. A number of randomized studies have shown this. Most of them are physiotherapists doing the studies, and all pelvic floor muscle training, really specific training, not just some shoulder bridge or pilates or something. It's muscle training. It can do something, but it does a lot of things, reducing incontinence postpartum, but it does not prevent prolapse. Because prolapse is a connective tissue problem more than a muscle. So that's when we thought maybe we should be doing something to the connective tissue and help the tissue restore after delivery. Why don't we put in a pessary? And we started with a trial looking at pessary. Which one? Okay. Well,
okay, die haben die noch für den ist okay.
So in this study we wanted to randomize women and looked at the primary outcome prolapse symptoms after 1 year as a subjective outcome, and we planned an interim analysis after 6 weeks. to see whether it is actually helpful anatomically. So we examined women 6 weeks after delivery. We powered it to see we had 29% of women having prolapse symptoms, and we wanted to reduce it by half, so more than 300 women we would have to really say it's helpful, and 80 women after 6 weeks to say that there's less prolapse when we put in a pessary. So what we did is really ask them after delivery, please take part in our trial. We want to prevent prolapse by putting in a ring pessary, which would still allow you to have normal lochia, and you shouldn't feel it that much, and you leave it in for 4 weeks, then you take it out and we examine you. So do you think women would be interested in doing that? No. Unfortunately, no. It was far too late to ask that after delivery, because they were quite busy with their children. The pessary didn't look very appealing, let's put it this way. Still, we managed to ask a few women and to tell them it would be really helpful to do that, and it doesn't hurt. It still was a problem. We had preference groups, so we said ring pessary or standard, which would be nothing in the first 6 weeks, at least in Germany. And if you want to have this pessary, you can have, then you go to the preference group, or if you want to be standard, you go to the standard group. And when we had a few women that said, oh no, if I take part in this trial, I want this pessary. My mother has some problems, I want to have this pessary. So we put in the pessary, measured the, on ultrasound, the height of the bladder neck, the descent. We looked at the pelvic floor muscle standing. This is when most women would have the prolapse symptoms, not necessarily lying down. And measured a few things objectively, and we had this validated pelvic floor questionnaire. We measured also the width of the hiatus, how it changed over pregnancy and after delivery. And this is an example of a woman before and after delivery. So the hiatus changed a lot, and you see on the right side, above the picture is the before the delivery, and this is after delivery. So there is a change in the pelvic floor muscles, obviously. So this is a poster we presented at the Ayuga Congress this year. I just say that we didn't manage to get our numbers, so it's not underpowered trial. We saw that it is possible, and I think that's the most important thing we can conclude is if a woman has symptoms, give her a pessary, and you can do so straight after delivery. We have to tell her, of course, if she has some feeling of pressure and if he feels that the lochia stop, then ask her to remove the pessary. We managed to tell them during on the telephone, so if she complained of something, we asked her to remove it. So we didn't have any sepsis or endometritis or something, so we didn't have any problems. We had 2 women that did not really feel comfortable with it and removed it. After 6 weeks on ultrasound, we had less descent of the bladder neck. We didn't have less symptoms, so the validated questionnaire didn't show that. We didn't have less prolapse symptoms.
How long did you leave the pessary?
4 weeks.
4 weeks.
Because we thought
why not 6 weeks?
You never have
no, we want.
This is a very, very early stage.
Yes.
So first of all, we have to choose another model, because this is ring shape is well, you need a longer distance from anterior to posterior than from right to left.
It's not anatomically.
It's not anatomically adequate. And but we had the problem when we developed new models, and it took me quite a hell of a lot of time and money and whatsoever. But you can only register new models and when you have proven that they are effective. So this is, you know, you start from the beginning. Now, it took me, we got licensed, and it took me the whole year in administrative work, stupid work I hate, that we are certified to develop and design and change models. Now I have the permission that I can at least change, and then there will be another very, very large examination according to medical device regulation, which is very restricted. So, but I have to prove, we had to prove in piggies, and then we have to do it as a customized pessary in single patients, then we have to write clinical reports. Only then we get certified, only then we can do larger studies. That is the step, and that takes really time. And I think I put a lot of effort and fantasy in these different models. We engaged a designer for 2 years, but I think it's needed because it's a gap. And still, we have to see, maybe it doesn't work. We have to control it with a media tab, with an ultrasound, with maybe MRI. So this is just the feasibility first step.
Okay, but the vision behind it. Maybe
I have
just to make sure that I
behind.
got it right. You have a woman where you're worried that she's running into prolapse somewhere, and she is a high-risk woman. You decide that right after delivery, and then you put the pessary in, leave it for 4 weeks, and hope.
But there's it's hardly any woman who wouldn't have a stage 2 prolapse after delivery, 1 or 2 days after this. They all had second stage.
So shouldn't you just put it in?
That was my idea. Was really to have put it into everyone. It's just to say you are. The data say the short, obese women are at highest risk to develop prolapse or pelvic floor symptoms. So just to put it in those, I think I see too many women that are slim, and I think that's not the way. I thought it's easy because it's 4 weeks doing nothing. Then I don't have to put it in and out and wash it or something. They won't have sex during the first 4 weeks. So why not have a pessary inside, which doesn't hurt, and just let the connective tissue heal? That was the idea behind it.
I think the idea is good, but I think it is much wiser when they have already symptoms in pregnancy to treat them then, get them confident, and then to continue maybe 2 weeks after birth or so.
So you have to approach it
from
earlier.
the pathophysiology, you think this is sufficient? What I mean, what you are doing is you elevate, you relieve the pelvic floor with a pessary.
Yeah.
Yeah?
That's what a lot of women said actually. Oh, it's very nice to have this pessary inside now because the pressure.
Yeah.
Yeah, but you know,
You think it's healing
I cannot talk too much because I think, you know, from Q pessaries they are also therapeutic because they massage the connective tissue, and we now made a model which has the suction part in the walls but open in the center so that all the discharge can go. And I think, I mean, what you have to reach is when you see lesions or over distension of the connective tissue, like in ligaments of the knee, you have to give support.
So you would vote for doing an ultrasound before, or?
Yeah, there are so few people who, no obstetrician is capable to do
This is what I'm missing. Did you recruit patients only with abortion, with rupture?
No.
We stratified for that. We
You
stratified
stratified
for
okay.
muscle avulsions. Just because, yeah.
But I think,
know that
I think to really be successful, you know, on one side we have in our societies, and it's again a political thing, the randomizers. In Holland you get a lot of money for each case. They randomize stupid patients, stupid things, without knowledge, always the same. Like we have heard today in hypertension, you must differentiate. And you must differentiate the lesion and then also adapt the model of stress.
So you need an ultrasound for?
Yeah, you need the knowledge of a pelvic floor ultrasound to know what you start with. And I think primary prevention is nice, but it's not the way we should go. We cannot, also in preterm labor, I didn't give every woman a Baessler.
Primary prevention would be not to be
secondary, yeah, well. I think you start with cases who really suffer, mothers really suffer, and they accept it, I mean. And you individualize to know what you are talking about, but all these obstetricians, they cannot scan. They don't know that you increase the risk of avulsion when you crystella. They don't know that you have a rate of 80% avulsion when you do forceps. You have not only avulsion, you also have the whole connective tissue damaged. And all these kind of all these midwives in their hospitals who are eager to do no episiotomy, then increase the second stage of labor up to 3 hours active, and are very proud that they didn't do an episiotomy. This is proven to do damage to the pelvic floor. But all this knowledge is ignored. As long as a baby is born, you know, it's sufficient.
The midwives,
yes.
They don't see the women.
Yes.
They see them for 6 weeks, at least in Germany.
Yeah, and they don't talk about it, but they don't know anything about scanning the pelvic floor. I mean, even the obstetrician.
We can learn it, we are not stupid. I mean, we would even love to learn it.
But you know, we had this wonderful talk. Yeah. I was a bit provocative. And I feel I get already nervous again. I really suffer from this, because she was at the Charité. She was not any longer. Our biggest hospital in Berlin has not even an urogynecologist. Professor Thun, who is experienced, is also not wanted. And the urogynecologists work at hospitals where there are no obstetrics. How can they close the gap? I mean, that is like in 500 years ago, the pediatricians were not at the women hospitals. But this has to be changed. And I mean, even, what you said, you are a wise person, you must have causes. No, I was provocative, but he is right, he is not vanished. But a lot of people, because they don't know, they are defensive. So this is also a political problem.
Isn't it surprising that on one of the slides of the first one, you showed that 50% before delivery, before pregnancy, have an incontinence?
No, in pregnancy. 50% in pregnancy. There was, I don't know, 3 or 4% before.
Oh, okay.
But that was retrospective.
Okay.
The first time we asked them was during delivery, during pregnancy and
okay,
it's changing. And Giacchiani is now doing with his wife Kani, who is an MRI specialist, a project, the first in the whole world, to examine the changes with MRI during pregnancy of the whole anatomy of the pelvic system.
Did you